Good afternoon. Welcome to a very special UCSF Department of Medicine Grand Rounds. The ground rules, I'm Bob Wachter, Chair for the Department of Medicine. The ground rules for the Grand Rounds are here. Put your Zoom screen in full window. If you have questions, type them in the Q&A box. Try to get to a few of them. We are recording this session and it will be available tonight on YouTube. And closed captioning, unfortunately, we don't have it live for this session, but will be available on the recording in a couple of days. This is a special lecture and always a special time for me. It's the Reza Ganji Memorial Lecture, actually the 23rd annual. Reza was a UCSF resident in the 1990s. I was actually his program director when he joined us after having been a Harvard medical student, where he was both a Marshall and a Rhodes Scholar. He had a tremendous interest in complex issues in healthcare, particularly ethics and health policy. And so the lectures over the years have been a who's who in those areas. Reza was one of the more remarkable people I've had the privilege of meeting in my life. He was absolutely brilliant, out-of-the-box thinker. And with the support of his wonderful family and friends, this has been an opportunity to honor his life for now over 2 decades. Normally, his family would be in the audience, about 30 or 40 family and friends that would always come. We'd have lunch with them afterwards. And I think it was one of the last in-person events we did last year. Michelle Mello from Stanford was our Ganji lecture. And unfortunately, obviously, we can't do that this year. So just to all of the Ganji family and friends, miss you. And thank you again for your support of this and for being with us. And we are pleased to be able to keep Reza's memory alive through this lecture and focus on some of the issues he cared so deeply about. This year's Reza Ganji lecturer is Atul Gawande, who I know Reza would have been a tremendous fan of because in many ways they share a lot in common, as I think you'll hear about. Atul needs no introduction, so I'll be quite brief. He's a surgeon at Brigham and Women's, a professor at Harvard, and the founder and chair of Ariadne Labs, which is a joint Center for Health System Innovation. If you haven't read anything Atul has written, I don't know what you're doing. Atul is a prominent writer, mostly in the New Yorker, where he's been writing since 1998. He's also written 4 best-selling books, Complications Better, The Checklist Manifesto, and Being Mortal. He's won all sorts of awards for his writing and his innovation and his extraordinary contributions to healthcare. From 2018 to 20, he serves the founding chair of a company called Haven, which was a healthcare startup sponsored jointly by Amazon, JP Morgan, and Berkshire Hathaway. For the past several months, he was a member of President Biden's COVID-19 advisory task force. He's just stepped down from that role. So we thought about having Atul do a lecture, but we thought it'd be more fun and engaging to have us have a conversation. So that is what we will do. So let me welcome you, Atul. And I know you wanted to start with a few words and reflections on Reza's life.
Thank you. I appreciate that, Bob. And I'm honored to get to deliver the memorial lecture or memorial conversation. In this case, I'd met Reza during medical school, but I didn't know him well. And yet I can see a lot of uncanny parallels in our lives. He had gone to Berkeley. I went to Stanford. He graduated just 3 years behind me. We were both lucky enough to get a Rhodes to get to study at Oxford. We actually ended up living, separated by a few years in the same college, in the same dorm, gone to Balliol College. We both were headed to medicine, but were hungry for breadth and studied politics, philosophy, and economics. The big difference is that he got a first, which is like the A+ of A pluses, and could continue onward for a graduate degree in philosophy. I wanted to, but I got a 2-1, which is basically a gentleman's B, and did not get to continue onward. We both went to Harvard Medical School. We both, in the middle of medical school, took a leave to go into public service and government. He worked for Surgeon General Antonio Novello in the Bush administration. I worked in the Clinton campaign and administration. We both ended up working for a period of time at the World Health Organization as well. I'm really sorry not to have really gotten to know him The fact that he died by suicide at the age of 30 is heartbreaking. And given his immense talents and the recognition and opportunities he was able to have in his life, his death, I think, speaks to the vulnerability that we all have, especially in this moment, this year of crisis, when we're all under duress and forced to be aware of the fragility of life by a virus that we witness claiming lives, for those of us who are in medicine, claiming lives at every age. It's difficult to think of this virus and this pandemic as a gift, but we should. I'm reminded of the work of Stanford professor Laura Carstensen, who had carried out a landmark series of studies tracking the emotional lives of people as they age. She followed people along. They enrolled in her study in Northern California. They spanned ages from age 18 to 94. And what she tracked at that time, they didn't have text messaging. She would beep them. Her team would receive the call from the pager when they called in, and they would be asked to simply report, what are your emotions at this moment in time? Are you happy? Are you sad? Are you angry? Are you frustrated? And captured little bits about their lives at random intervals over years. And what she ended up finding was what people's emotional signatures are. And she found that that our signatures change as we age. There is an older signature and a younger signature. We have different desires as we age. In our younger ages, it's about acquiring, it's about getting, it's about achieving. And as we head into the later years, it shifts from that to more interest in intimacy, in being closer to people. Our circles go from trying to widen them and become more and more networked to wanting to have deeper, closer relationships with much smaller numbers of people. The emotions change as well. In older ages, for example, people become capable of certain kinds of feelings that you don't even recognize at a younger age. For example, people become capable of experiencing poignancy, that bittersweet feeling of both sadness and joy at the same time. One of the things that was really remarkable that she found was that as people got closer to the end of their lives, as they got older, they became happier. That's counter to our image of becoming old and frail and fragile and subject to the risks of life. But they became happier. They became more at peace, even as they brought their circles in and stopped trying to acquire so much. They had a decline in health, they had a decline in ability, but not a decline in well-being. In fact, an increase. And people call that wisdom. And the puzzle is, why does it take so long? And there's been a lot of theorizing about why would that take so long? The theory most commonly heard is that it just takes time. You have to build up experience of what those other parts of your life are like before you can get to that space. And that theory was wrong. And she learned it, Laura Carstensen learned it because of a couple events that happened along the way. One was HIV. And she had subjects in her study, young men, who then changed from the young trajectory, the young signature of emotions, to the older one as they became sick and faced the fragility of their lives. And she realized this was the older signature was a matter of perspective. Those people, when they became sick and nearing and coming face to face with their fragility, drew closer to those who meant most to them. They focused less on achieving and acquiring, more on intimacy, and they became more at peace with their lives. They actually became happier, lower rates of anxiety, lower rates of depression. And the lessons from this for me are that well-being is more than health or wealth. And many people are learning that in this crisis. I am seeing it everywhere. People are changing their focus. They're changing their jobs. They're changing how they live. There may yet be good to come out of this. And for me, that's what getting the chance to give this Ganji lecture and conversation with you, Bob, really called to mind.
Thank you, Atul. That's really profound, and I think gives us food for thought, because there's probably some of it that you could will yourself into and think about, what are my priorities? And you're right, this gives us cause to think about that in a more serious way than we probably have before. What else? We'll spend a little time, given the breadth of your interests, there's so many things we can talk about, so we'll move around a little bit. We'll start with COVID. What did COVID reveal to you? You've already talked about something it revealed about the way we approach our lives and our mortality. But what did it reveal about either our healthcare system or our society, or the combination of the two, that you didn't fully understand before?
Gosh, so many things. One that it revealed was probably the fundamental, there were a lot of rankings of pandemic preparedness of countries around the world. And the United States was consistently #1 on pandemic preparedness. And places like Vietnam and Thailand, they were not in the top half. And the performance in this pandemic, in fact, proved that what they were measuring was not what was important. I had underestimated, we learn it as a core dictum of public health that your single most important tool is communications. But the ability to communicate as governments in one voice with the government officials and the public health officials aligned about the truth of what really happens. That is the single most powerful thing in this pandemic it's just demonstrated to an extraordinary degree. The places where people did not politicize and did not go on the attack against their public health officials are the places that have performed the best. And the places that could turn from that have been able to perform the best. There's example after example around the world. And that's one of the most important lessons that I feel that I see. There are many more that I'm happy to go into, but let's start there.
Stick with that for a second. In your article this week in the New Yorker, you quote Gandhi, and you say, "Peace is not the absence of conflict, but the ability to cope with it." Did this demonstrate that we as a society have lost our ability to cope with it?
So I did a long piece in the New Yorker where I started tracking and following along a city council in Minot, North Dakota, which is in the county that had the highest rate of spread in the fall, in the state with the highest rate of spread and hospitalization, in the country with the highest rate of spread and hospitalization in the fall. And my puzzle was, can we pull together to actually solve this? This is a state that had been, there'd been strong opposition to the basic mitigation measures, including wearing masks. The infection rates were just climbing through the roof. You had hospital leaders crying out for weeks, saying that, danger's coming. Their beds then started to fill up, and still action wasn't being taken. And my puzzle was, can a democracy pull together as frayed as ours to actually take on a crisis? A lot of people have read that article and felt it was just utterly depressing. But I actually thought it was a hopeful story. On the most basic level, you had the two forces pitted against one another. Those who were speaking from the public health voice, those who were speaking from what they called the pro-freedom voice. And it was a pitched battle, and it continues to be this day. You don't get to consensus. If you expect consensus, there's no red America, there's no blue America, there's just one America. That's not the reality, and that's not what's going to happen. But what you did see was, the city council voted and put in a mask mandate when the worst was upon them, and it was clear this was not a flu. And though there is a subset of the population that continued to argue that it was a little more than a flu, 90% of the population followed along and got mask wearing to 90%. most or all of the time, as good as it was anywhere else around the country. That was a crucial part of, along with people deciding to stay at home instead of being in the bars and restaurants. And those numbers were enough that the rates of hospitalization, the rates of cases, and then ultimately the rates of deaths fell massively. I mean, they are now down more than 90%. The further question is whether we can keep our foot on the pedal, but that was a sign to me that as riven as we are, we are capable of coming together around the most important things that matter.
Yeah, I guess, but we didn't mostly. And I guess the question is, does this expose the current state that we're in politics? You might say, we've had periods of partisanship and division in the country. And if you look at the arc of history, it always seems to get better. Is there something fundamentally different about now, maybe because of social media or Fox News or whatever, that people are seeing their own reality and can choose their own adventure, which augments partisanship in a way that it's not obvious to me sort of how we get out of this mess? Do you have a theory of how we get out of this mess if we do?
Well, a couple things to pull apart here. One is, this is a uniquely politically fraught virus. The data has come out now showing that 76% of the spread of cases are from people between the ages of 20 and 50, and 93% of the deaths are in people over the age of 55. So we have to ask those people at the younger age to submit to major disruption, complete disruption of your life for an invisible virus that does not have an effect doesn't reach deaths until 3 to 4 weeks after the cases start cropping up. And so you need action now in the face of an invisible thing for the sake of a population that's much older. And you can have politicians exploit that. And we've seen politicians exploit that, not just in the United States, but Brazil and other places. That is a vulnerability of this virus. And it's layered on a time when there are much deeper divisions. I also had an article that came out in the midst of this around deaths of despair and what the story is over the fact that we also had declining rates of life expectancy in the United States, and it was particularly that age group that were affected. It's the 20 to 55-year-olds, especially 45 to 55-year-olds, who have a higher rate of suicide, higher rate of alcohol-related death, higher rate of opioids, and skyrocketing. We managed to ignore the climb for more than a decade. What we hear is the anger of the high school only educated, middle-aged white American. What we see in much larger numbers is the despair that if you have a high school education, your prospects and in the economic future you are offered, and by the way, that is 70% of the country does not have a college degree. This is the average taxpayer. And us in the knowledge worker world, where we get to be the winners in this economy, don't have any of the same experience of being part of an economy where the average person is worse off than their parents were. And that experience is driving a big part of what's going on as well. It turns up as anger, it turns up as exploitation, it turns up as tribalism. And we have a lot to work against. It's a global phenomenon, not just an American one.
Yeah. Let's talk about COVID for a second. You were on the task force, and I know you and your colleagues on the task force, we actually had a couple of your other colleagues, Eric Gooseby and Rod Rodriguez on last week, have just penned an editorial about where we are. And you can paint an optimistic view of vaccines and how wonderful it is, and the Biden administration seems to be on top of it, and a more pessimistic, the variants are coming and we're in trouble. Where do you land on that race right now?
I am, of course, on both. I think we are moving. We're in the top 5 now after a shaky start in vaccine administration. The vaccine rates of administration are climbing enormously as we get better and better at deploying. And as we also have had a consistent national message of pulling together around making this work. I'd point out, it is a very big deal that every other form of fighting the virus has divided us politically, whether it was testing, whether it was masks, whether it's restrictions. This one is not. We are pushing the vaccine forward, and the main anger is how do I get it? And that's a good place to be. I also agree with my former members of the Transition COVID Advisory Board. We penned an editorial that was in the New York Times just today about how unless we take action now, the B117 UK strain is doubling every 10 days. So all of the other strains are falling rapidly. This one is doubling every 10 days. In Florida, it's reached 4.5% of all COVID cases. It'll become the dominant strain in the next 4 weeks or so. And the reality of this strain is that as fast as we can drive vaccination, the supplies won't let that be sufficient to stop it. The vaccines are effective against this strain, but we need to do a few more things. The things we recommended today were upgrading our masks, and we should be, as a public, wearing masks that are much better fitting with the clips over the nose, so when you talk, it doesn't flip down to below, and it has a tighter fit. Ideally, it'd be the medical grade masks, and I would really be happy if we started sending a package of surgical masks to everybody in the country and signal that's important. Another critical step is to continue. This is not the moment to be opening bars, restaurants, starting weddings and funerals, and all of that is happening. We had more than 10 million people host Super Bowl parties, and we're starting to, and we're going to see a rebound from that. This is not the moment to do that. The further thing is that we need to also start doing something about workplaces that are not following good safety measures. Most workplaces where people are coming into work, we have underestimated how much, we talk a lot about the bars and restaurants, the social situations. The biggest area of spread is in workplaces. Oregon puts out a weekly list of all the workplaces that have had outbreaks. This week's list has 102 workplaces with outbreaks from 5 people to 760 people. These were McDonald's. These were local clinics, including a dermatology clinic. These are shops. These are warehouses. These are prisons. And the amount of spread going on because we have too many workplaces that have not taken the critical measures is, even in a place like Oregon that has pretty tight restrictions, these are a big driver, and we have a lot more to do there.
Yeah.
So work to do if we're in 2 months to avoid the 4th surge. I think it's possible to, but that's where we are.
Yeah. Can you see any way that happens politically? You sort of have to have some sympathy for the poor governor or city health official who says we need to stay shut down now as people are looking at this curve of cases just in free fall. It's a really tough position for them to be in.
Yeah, I mean, this is the cost of a year of not having been together on the messaging and being super clear. We've had 4 weeks of consistent, actually, one of the interesting things is that once the President Trump's attention shifted to the election instead of COVID, he left the field of attack on public health officials. And we've actually had pretty consistent messaging since November. The polarization around the messages are reducing. There's definitely not consensus. I mean, we have ridiculing continuing about, the virus, about whether we should be in masks and all of those things. But we really, around the country, we're at close to 80% wear a mask all the time. We're at 94% wearing a mask, reporting they wear their masks most or all of the time in public. And the number of people who have not, today reported that they've been in an environment where they had more than 10 people in the same room outside their household, that's gone down enormously. So, I think it is possible to say we can need to keep the foot on the pedal. We're not totally letting up, but yes, in those Midwestern states, you have governors who feel, in some cases, quite ideologically, in some cases, because they are responding to a very loud opposition, there is the relaxing going on. We could be sending a sharper, clearer message as public health folks that about we've seen it over and over again. If you don't act to control it, we still have millions of people actively infected in circulation around us. We're still at 3,000 deaths a day. This is a message we just need to keep working.
Maybe one last COVID question before we pivot to a few other things. Obviously, COVID has exposed issues in health equity that have become sort of impossible to ignore and happen with the confluence of the other issues we're talking about in racial justice and in terms of the murders. And yet those of us who've been in healthcare forever know that these are not new issues. How do you think that's going to play out? Do you think this is going to have staying power, that this is a moment of reckoning and the society will take this seriously? Or do you think this may erode when COVID goes away?
It's already eroding. I mean, we've seen with vaccination the challenges and the reality of not seeing vaccination uptake because of issues of trust, and vaccine delivery because of the way our healthcare system is organized, moving to the places where infections are greatest and most in need. It's also clear people are very aware of it, and we're having an earlier dialogue and recognition of these problems and a much more creative and focused effort to begin remedying some of these issues, opening vaccination centers, pulling people in. But even among healthcare workers, we see 50% and even 100% higher rates in the white population as opposed to our Black and Hispanic populations, and that is a sign of all the issues that we're struggling with. It is I would say a couple of things. One is we're talking about it earlier, and we're actually moving faster. There's a lot of interesting creative things that are being done. I'm part of running healthcare mass vaccination centers in Massachusetts with a organization I founded called CIC Health, and we're running vaccination at Fenway Park, at Gillette Stadium, but also starting next week at Reggie Lewis Track and Field in Roxbury, Massachusetts, where we're trying very creative methods that make vaccination accessible to the local population. That includes taking blocks of scheduled time, opening it up earlier to give it to the community healthcare workers, to major healthcare groups that reach people door to door, canvassing to get people signed up and get access to these appointments where you don't have people who can easily sign up online or don't know about it or think it's not for them or don't know people who recommend it, and getting it in the hands of those who are connected in that community is a critical part of making this successful.
Let's pivot a little bit to your career. You've already told us you were a mediocre Rhodes Scholar. I'm not quite sure how to interpret that.
Mediocre philosopher.
When did, and without any false modesty, you're a spectacular writer. When did you discover that and decide that it was going to be an important part of your career?
I am proof that you don't have to be born to be a writer. I was not a good writer. At Stanford, my lowest grades were in writing. At Oxford, what I loved about it was you had to read your essays out loud, and it was embarrassing to read my essays out loud. They weren't logical. They didn't flow. The Don would stop me and just my goal became to just try to get through reading an essay out loud completely, because they'd stop you and just say, I can't stand it anymore. this makes no sense. And that kind of forces you to learn how to think structurally and analytically and pull it together. But it wasn't until midway through my surgical training that I really found writing. And here I have to cite you, Bob. You and I had a conversation about a decade ago. You won't remember this, but you mentioned a piece of advice you got before the age of 40. Say yes, and after 40, say no to everything. Mm-hmm. And that presented what I had. It really stuck with me because it presented what I had sort of stumbled my way into as the way I navigated. So even in surgery, if I thought something sounded cool that someone offered to me or was out there, I would just say yes. And in the middle of my surgical training, I had no time. A friend started up a internet magazine in 1996 in Netscape Navigator days. Real journalists wouldn't write for it. And he said, would you write something for us? I need some copy. I was out of the administration at that point. I was a resident, and I was trying to figure out, how do I get to public policy issues and connect back to this stuff? And this, I thought, would be a way to do it. So, okay, yes, I'll give it a try. And what I took away as your lesson was that you say yes to everything, you try it and you see if you actually have the energy to do it. And if you don't have the energy, stop doing it. Mm-hmm. And don't worry about what you thought you were supposed to be. So as a surgeon, I'm sitting there, and at 10:30 at night, I'm making the time. And I had the energy for it. And I wanted to do it. And I paid attention to that. And, I ended up writing for that magazine. It was called Slate, became Slate Magazine. And then the New Yorker picked me up in my third year of residency to write one article and then another article. And then I became a staff writer in the fourth year. And just somewhere along the way, I was getting so much pleasure out of it and gratification and a sense of it advancing my thinking and so many other parts of what I was doing. By the time I had accepted that role as staff writer at the New Yorker in residency, I knew I just had to figure out how to hold these things together without it just flying apart. And with time, it took a long time to figure out how to make it viable, but it did come along.
Yeah, well, it sure has. I was thinking before we started about, the most prominent people who still operate as surgeons. And I think we decided maybe Mehmet Oz has more followers than you do, but you're up there. How do you deal with the fact, the patient, you walk into the patient's room and the patient says, "Oh my God, you're Atul Gawande. I love reading." Get the patient in the headspace of, I'm your doctor, I'm your surgeon, you can trust me. When I'm sure you have that conversation all the time with patients.
Actually, not so much. Everybody Googles you. They see who you might be and what your background is. But I treat primarily cancers. I do endocrine surgery. And when they come in, all they're thinking about is their problem and what they've got. And sometimes in the post-op visit, it will shift to these other things. And can you sign this for my daughter or whatever? But honestly, at the beginning, they're trying to decide who they want to come in to see. I think even though my first book was called Complications and all about the errors I'd made, and the fourth book is called Being Mortal, I think that sense of feeling you might know me a little bit, or at least if you read about it on the internet, you might feel like I have a track record. People feel a little more comfortable sometimes choosing to come in. And, but, within 5 seconds, you're talking about their cancer. And that's all there is. That's all there is in the room.
Yeah. Let's maybe focus for the second on complications and being mortal. How do you decide whether to be a character in one of your own stories?
Essentially, I'm a character in all of them. My assumption is you're aware of my perspective, and I have to figure out how to take that into account. I'm biased in my own ways, right? I'm a surgeon in at the Brigham with all of the kind of narrow perspective that brings. And then I have to figure out how to break out of that and enable myself to see and you to see more than what I might see from purely that individual perspective. And I'm very aware that my voice is one where I'm curious and I let that come out. I let the curiosity, I let the willingness to follow the thread where things go come out. My assumption is that you can't suppress who you are, the subjectivity, that I am a character. I think that's very influenced by a lot of the nonfiction writers that I've admired, or fiction writers, whether it's you know, Hemingway or Stephen Jay Gould, or a range of folks, Oliver Sacks. You are, you know the voice they're bringing. You see the perspective they're coming from, and that is part. It shifts from being a constraint to being, if you can get it right, to being part of what allows you to trust navigating through, or at least understand who you're with as you're seeing the topic or the people you're getting to meet in the course of the story.
Yeah. Yeah, and I was reading the piece on, it's Minot, is that how you pronounce this town?
They actually say Minot.
Minot, okay.
Yeah.
I was reading about Minot last night, and it struck me that Minot was an example, as was McAllen, Texas, of you choosing a worst performer. Again, and you do it very sensitively and sort of help us understand why it hasn't done well. But in other cases, you've chosen best performers, the Cystic Fibrosis Network, or the Hot Spotting, or I always wanted to ask you whether you really do like the Cheesecake Factory, but there you go. How do you make that choice, whether to choose, as you're trying to figure out the subject of something, how do you choose the subject, and how do you decide whether the exemplar is somebody or something that does it really well, or somebody that does it really poorly?
Well, there's so many things I have to say about that. First of all, I'm very interested in variation. I'm not as so interested in averages. It's the whole distribution. And when I'm thinking about what I want to talk about, I'm often thinking about what part of the distribution helps me understand this problem. Is it going to be by looking at the best performer? Is it going to be by looking at the worst performer? Is it going to be by looking at the 40th percentile? And I really do think hard about where I can see the distribution, get a good grasp of it, and then go inward. I'm always thinking about whether what I'm capturing, depicting, the topic I'm covering, the angle I'm taking in my research or in my writing is able to capture this. For example, on the surgical checklist, when we did our research trial, WHO, I'd been tasked by the World Health Organization to identify guidelines for safer surgery, because the volume of surgery was exploding around the world and the safety and quality issues were becoming major. And I was very conscious that, I was being asked to focus on the low and middle income world, but I thought that the systems were broken everywhere. Mm-hmm. Again, on a continuum, but the performance was a fundamental one in which we didn't have basic systems in place. And so when we decided to do the research trial, I very consciously lobbied and won permission for testing, not just in, a refugee hospital in Jordan and in Delhi and in Ifakara, Tanzania, and in Manila, but also in London and Seattle and Toronto and Auckland, New Zealand, because I wanted to determine where on the spectrum does our intervention help, where doesn't it help? And as it turned out, it helped in every location and helped dramatically. And that notion of healthcare is this enormous production, and it's happening everywhere. And part of what I spent a lot of time trying to understand from a research point of view and from writing is, what's it like to be a human at this time, experiencing this system? Where do we have zero control? Where can we have some control and shape it in the ways that we might want to?
Sort of a nice departure to your efforts to shape the healthcare system. Let's talk for a second about your innovation center. What motivated you to do that, and what are you proudest of as now it's been going on for several years? And we'll talk a little bit about Haven and some of the challenges with that.
Yeah. So the theme, I think, that emerged out of surgical training, the other thing I did during surgical training was take a little time off to get my master's in public health. And I didn't know how to stick these three things together. I was writing about problems, I was practicing, and I was then thinking about, doing data analyses, but I was especially interested in the public health side of how do you do interventions? How do you do clinical trials on systems and make them work? And I discovered there was this like virtuous cycle of seeing the real world and experiencing it every day and the mundane everyday problems of trying to practice, executing, writing about the problems like why is the cost so high, or why are there failures, or different aspects of it that brought hypotheses, and then the ability to create innovations that you could test in that real world. It was writing an article about Peter Pronovost, creating a checklist that reduced central line infections to 0 in the state of Michigan. And I just was so blown away by that study. He'd done an entire state, treated it as a laboratory, changed the care, and eliminated a problem that we just took for granted as like an unavoidable thing that, hey, it kills people 15% of the time, what can you do? And I said, boy, if you could do that with that simple procedure, what can we do with our work in surgery? That led to rolling out a trial, developing a tool, rolling out a trial. When that study came out showing a 47% reduction in death from deploying the surgery checklist, that led to a lot of interest in, can I create this for other parts of the medical experience? Birth, we selected birth. We selected care towards the end of life, serious illness, and then ultimately also the primary care journey that people go through in their life, and said, what are the protocols that could shape those? And so there was an innovation aspect of things. And then there was, okay, we've got this trial that shows benefit. How do we drive it to scale? And said, okay, over 5 years, can we innovate and implement? I soon found it was more people, more money, and more structure, lack of structure than I could handle. And that created Ariadne Labs to provide a platform to attract people who want to solve those kinds of problems, generate new solutions, test them in the real world, deploy them. And then at 6-7 years in, we had demonstrated we could deploy the Safe Surgery Checklist. Scotland, for example, in a partnership demonstrated they executed across all of their hospitals in Scotland through a combination of training and mandatory requirements, and achieved a 35% reduction in mortality sustained for 6 years, more lives saved than died in car accidents by 5-fold every year. And get the Safe Surgery Checklist to 90% of the high-income world, 60% of the lower and middle income world, and keep trying to close gaps there. And some wins and some equivocal findings that we're still trying to make better in parts of the other aspects. And now it's 150 associate faculty, it's 100 staff, and a whole portfolio that has become incredibly exciting. And it's just, it's just like one step after another, you suddenly find this thing has grown.
Yeah. All right, let's turn to Haven for a sec. You were doing, everything was going spectacularly well in all three sort of pillars of your life as a surgeon, as a writer, and as an innovator and doer. And all of a sudden this opportunity comes. What did you find attractive about it? And as you kind of came into it, how clear-headed were you about sort of the risks and the opportunities?
Yeah. So suddenly this opportunity, there were many opportunities that came along, and I had resolutely said no. I had built Ariadne Labs as a place that I would be very happy to spend the rest of my career working. But the frustration was there were two things that you need to create change at the health system level that we weren't able to affect. So we could create protocols, we could partner with both with providers and patients, but what we couldn't deal with was being able to change technology, and that was an important part of what we recognized to be able to do. And we couldn't change the incentives in the system. We couldn't change the way people were paid, how insurance worked, those kinds of things. And so having three massive companies with capital they were willing to put, a long-term view they were willing to take on behalf of 1.5 million low-income workers, the very people who were most affected and left out in our healthcare system. So, if you're the poorest, if you're in Medicaid, you actually get one of our best health systems because you have no copays, no deductibles, no premiums, and assured care. But if you are just above that line, working full-time, making $12, $13, $15 an hour, you have the average American at work has $2,000 deductible and have $400 in the bank. And they are routinely skipping care, routinely unable to make these systems work. And I'd been trying to whack away at those problems and didn't have an obvious way I could do it from Ariadne Labs. I knew that there were aspects of that problem we couldn't solve without government. We weren't going to be having that government in place for a while. and I needed to know how to change the technology. And there was a chance to learn how to work with technology, to learn how to build insurance plans, to learn how to do all things we needed to do. It reminded me of the key thing that came out of it for me was we got to build an insurance plan that deployed to almost 150,000 people with no co-insurance, just co-pays, no deductibles, kept it at the same price, made it so it was inexpensive for free for 60 drugs that were critical for people to do well, plus inexpensive for mental health and primary care, and make it financially viable and deploy it. It was popular with the workers, and you could deploy solutions and make them work. And there were many other things I got to do. Those are companies where you had to do it without disclosing what it was. And I think if not for the pandemic, I would have been continuing to power ahead doing many of those things to keep them going. I think the pandemic really changed a lot of the reality of what was going to matter. And one of the things I pivoted to was then building CIC Health, which I mentioned, as a way to get to many more in order to get testing costs down and testing deployed, and could work on incentives in that setting. And then and now it's adding in mass vaccination.
Do you think that the closing down of Haven was just a casualty of the pandemic and the timing, or does it say something more profound about the ability to transform the healthcare system? You think about three companies with unlimited wealth, an absolute all-star team of leadership, and still, I think obviously you built some things that have staying power, but I think most people will look at it and say it was an unsuccessful experiment. What does that say?
Yeah, I think a couple of things. One is that very clearly a critical decision was whether Haven would become the benefits office for all of the companies. And it became really clear as we went along that as we thought of ideas and generated them, it was really going to need to be implemented, and it was just very different deploying at Amazon, Berkshire Hathaway, and JP Morgan Chase. There are different cities, different populations, exceedingly different cultures of organization. And once that became clear, then Haven threatens to become a very expensive think tank, right? Where you're generating ideas is getting implemented locally. We generate a lot of ideas that created a lot of value, lowered the cost of drugs, improved the insurance, et cetera. But it didn't have that potential to say, we'll take over all of the benefits and running of the insurance for the three organizations and then add more and more and more and more. It was very clear all implementation is local, and that was not going to be necessarily something you could overcome. I'd say the second thing about the prospect, you know, there was a lot of hype and it was difficult to counter about the notion that this is going to be what saves the healthcare system. It was very clear there's some things that a private sector can improve. They can improve the cost and outcome, you know, the outcome per dollar. They can improve the experience of care for the people in the system. But we have an employer-based system. A job-based system is a broken system in a world where people are moving every couple of years to different roles in many, many kinds of jobs where, and the pandemic has brought this out in spades, the vulnerability we have of tying your healthcare to your job. And that remains still a big hill to climb, and the government has to solve that. That is a public core issue that we still have not faced up to.
Yeah. As you look at your own decision to take the job, it strikes me that everything you've done, you know, every book has been a bestseller. You've done incredibly well with everything, and this didn't go that way. And they say failure is the best teacher. I've always found that overrated. I prefer not to. But is there something you learned about yourself in this process that you know will carry with you, and that it was a different lesson personally about the choices you make than lessons you'd learned in many? You know, you've done so many different things.
Yeah, you know, I've had, I'd say there's a couple things. One is that to me, they've all been, you know, for example, I was in the Clinton administration. We didn't pass healthcare reform, right? I worked for a solid year on that. We didn't pass healthcare reform. And yet it was one of the most formative experiences for me and a whole generation of healthcare policy folks who came, you know, and saw that the ideas lived on, many of them captured and implemented 19 years later with Obamacare. Mm-hmm. And I think in the same way here, there are a ton of things that I felt were enormously successful. We had amazing people. And then I could not have built the mass vaccination and mass testing program that we built. We're partnered with the Broad Institute in New England, which, you know, we were able to support their ability by arranging the logistics and operations that have delivered tenfold increase in access to testing, and then open new labs in other places around the country. We've been able to build the software systems and the execution at CAC Health for mass vaccination centers. Of note, because I'm writing about these topics, I don't take any income from any of what I've formed, but I could not have done those things. I wouldn't have known how to find the COO. I wouldn't have known how to build the tech team without all that I learned in the experience at Haven. So I'm hard pressed to say that it's been a failure. It definitely did not become what we thought it would be. That's the reason it was dissolved. It was not going to be the entity we thought. And yet the outputs and what we created and what I got to learn about how to execute on continues to live on. So I just feel like I just keep bouncing from fantastic experience to fantastic experience.
Yeah.
It's been a very, very charmed life.
Yeah, no, I wanted to hear you in some ways tell that story, because I think people often, particularly, you know, younger people, see something that didn't go exactly as they expected. And I don't know any successful person that can't tell 10 stories like that and how valuable they were. And the lessons, you know, in some ways were more valuable than the ones that came from success. One of our viewers, sort of on that theme, but getting down more to healthcare delivery, said, can you discuss the heroism of incrementalism? He or she quotes an article, I hope correctly, that you wrote: "We devote vast resources to intensive one-off procedures while starving the kind of steady, intimate care that often helps people more."
I think this is really fundamental. Asaf Bitan, who headed our primary healthcare program at Ariadne Labs, and then succeeded me as the executive director and now runs it while I chair it. Asaf and I used to have an ongoing argument, it's kind of tongue-in-cheek, about who's creating more value today, right? Me, the surgeon, or you, the primary care? And then he came armed with all kinds of data, finally putting to rest any notion, you know, like, I can actually give you all of the kind of cost effectiveness analysis about the value that surgery brings, and it's substantial. I can prove that building a district hospital in a middle or low income country that delivers 50 core operations and surgery is as valuable as a vaccine in the value that it creates over the course of a person's life per dollar. But what Asaf really helped me open my eyes to is how much the world of healthcare as a whole has changed. It isn't just about the vaccine or about the surgery. It's about the difference between accompanying people over the course of their life and that person having a clinician who knows them, understands their goals and needs, and is able to connect the dots to make sure that when they're in need, they're seen in a timely way, they have their problems accurately articulated, and identified, they have the assets and resources of the giant healthcare system brought to bear in the right way. And then when it fails, that there's someone there to make sure, okay, that didn't work, but this is the next step and we'll get you there. And the value that a relationship with primary care creates adds years to people's life expectancy and is critical to the functioning of the healthcare system as well. And that reality that you cannot achieve your average 80 plus years unless you're able to afford your needed care and treatments and have a clinician who understands your needs in continuity over time. I think that's incredibly powerful. We have rewarded rescue in the middle of the 20th century when we built our healthcare financing system. That was the primary thing we could do. We could give you a penicillin treatment for pneumonia, or we could give you an operation. We didn't even know there was high blood pressure, let alone know how to treat it. And fast forward to now, we can do many things, ranging from controlling your blood pressure over time to managing other chronic illnesses, to recognizing through genomics or your social determinants what the major issues are that will affect your life 10, 20, 50 years from now, and make that kind of a difference. We're in a system, a job-based system, that only cares about the costs this year. That's why we have fights over whether we'll pay for hepatitis C treatments that cost $50,000 and up, but avert $1 million in costs in the course of your life. We need that life course commitment and view, and we have not aligned around that. That is, delivering that is a global gap. I founded with Asaf and a group of people at the Gates Foundation, World Health Organization, World Bank, UNICEF, a group called the Primary Healthcare Performance Initiative that ties everything from how loans are given to countries to public health supports, increasingly tying it to how you make visible the function of your primary care system and its abilities. And I hope that's able to grow over time.
Well, Atul, this has been spectacular, and I know Reza would have loved it, and been the fact that you and he have so much in common, I think, is particularly special. And I am grateful to you for taking the time to talk to us, and for all you've taught us over the years, and will continue to teach us about how to deliver.
I hope I got to hint a little bit at all that you've taught us as well, Bob, and all that you've taught me. I've valued our friendship over the decades. That's
incredibly nice of you. Thank you. Thank you. And thank you all for tuning in today. As I said, we will post this tonight on YouTube. Also want to do a program note quickly. First of all, we have our crack production team up there, so thanks to them. Next week, instead of Grand Rounds, we will have the Philip Lee Memorial Lecture. Phil was the founder of our Institute for Health Policy Studies, former chancellor at UCSF, former Secretary of Health, where he pioneered some of the key innovations in the federal approach to healthcare in the last century. Really a remarkable person. We were lucky to have him with us at UCSF. So a memorial for Phil Lee next week, and then we'll be back with Grand Rounds the Thursday after that. So until then, stay safe, and look forward to speaking with you soon. And again, thanks to Atul Gawande for a spectacular session.